Okay, welcome to another install of the Rapid Review. So this one, I'm going to change my view here. So this one in particular is regarding shockwave for spinal pathologies. So I've done one in the past that was surrounding the use of shockwave with regards to treating things such as nonspecific low back pain or low back pain in general. The majority of those studies were really focused on, and they continue to be focused on as we review the literature, on the more of the outcomes measures, clinical significance with regards to, performance, pain, and sort of the non biomechanical, physiological, or pathophysiological outcomes. And so I've been asked, what are the details there? How can we better explain this potentially to patients? So I'll give you a little bit of background and even talk a little bit about maybe how I talk to patients, and I want to, cover a quick case study as to, the thought process in terms of this implication. So this is far from an exhaustive review, and it also includes animal models, which again, I know a lot of people don't really think that it's very helpful. But again, if you're evaluating the basic science of literature, that's kind of where it starts, is the animal model approach to determine the efficacy and whether or not we should really move forward with something. So related to that, we do see that there are some animal models, but even then, they're fairly limited, because at the end of the day, I think, most people are interested in these outcomes. Typically, they include pain, performance-based indicators, and the longevity of an outcome. That might also include cost of treatment and whether or not it's cost effective to utilize a particular approach compared to some of these other approaches. And then we also do see some of those other comparative approaches. So I want to, sort of reiterate some of the literature that may not be specific to the pathological process, but just to reiterate, some of the comparative studies that are done on certainly other regions of the body to facilitate, some of the changes that we may be looking for in comparative tissues that we're dealing with in the spinal pathologies. So, for example, I think what's very interesting is we look at the protective mechanism effects in specific tissues. So again, previously I've outlined the neuroprotective effects, and I left some of that in here as well. So what do we mean by protective effects? Well, we're looking at, further degeneration of a particular tissue, either in the exact proximity or in the adjacent. So for example, in the neuroprotective mechanisms, in studies that have been done on animal models and subsequently in some humans, to where there may have been a spinal cord injury, either as a result of an accidental process in some of the human models, but in the animal models, obviously they induce that specific injury. And then, of course, we know, the mechanisms associated with the neuropathic effects that are going to happen to the peripheral nervous system, and even potentially distal in the central nervous system. So, studies have found that there is a neuroprotective effect in that, minimizing that continued degeneration to the peripheral nervous system in creating that neuropathic effect. I think what's also interesting is identifying, that specific component. So there is differentiation in Schwann cell production, but part of that mechanism that we also see in the myo, the chondro, and even the osteo, to where it also minimizes the apoptosis effect, which is, again, partly interesting because apoptosis is also part of the typical tissue matrix disruption, the insult that we find with some of these higher energy densities in utilizing shockwave. So what that implies to us is there's some interesting to the protective mechanism, but in sort of aligning itself with the physiological process and where the body's trying to minimize, necrosis to a healthy tissue, to the existing tissue profile that does belong in a particular area, while, potentially inducing more of a degenerative or reabsorptive effect of the tissues and structures that typically do not belong in an area, such as fibrosing or calcification with regards to a tendon. So we see these protective mechanisms. We do see an increase in metabolic activity through some reactive oxygen species, also related to the reactive oxygen species, mitigating free radical production and oxygenation, and reducing excessive fibrosing, which is something of particular importance. Neogenesis in specific tissues. So we see neogenesis in neural tissue, chondrocytes, osteocytes, myocytes, tenocytes, neovascularization. So it's been highly regarded as a neogenesis effect in tissues that have been treated with that. And again, when we look at the spinal pathologies, and that's something of relative performance. And again, just to reiterate, where a lot of the literature eventually went to, which was the performance-based outcome measures, including pain, which we know is subjective. And the reason I think there's the question surrounding the use and specifically identifying the physiological processes of a particular approach is, is it better than something else? And I think what we found, and hopefully I'll provide a little bit more evidence to the effect, is, supporting some of the influence that it may have that may supersede its effects over some of these other, conservative types of approaches. So for example, there have been some comparative effects in other physical agents and showing some similarities. And then one still must, evaluate that and determine, where the cost effectiveness is, where the longevity is, and part of the time course in that effect. So if we do a comparison, and for example, low intensity pulsed ultrasound, LIPUS as some people refer to it as the acronym, in that, how long does that take, and what is the associated relative cost, but also, the ease of use and application, and the conservative nature at which the physical agent is going to be applied. We also look at relative side effects, so if they do have an implanted device and we can't use something of an electromagnetic nature as the application, obviously focused shockwave is an electromagnetic cylindrical coil device that generates its energy, but that's not the application. The introduction of the energy is acoustic and then becomes mechanical in nature as soon as it hits the tissue. So therefore it doesn't carry the contraindications that some other physical agents may actually carry. And then of course we look at the number of treatments, and they're fairly minimal. So let's quickly just review this again. This is not comprehensive, but this is a particular study of interest to me because it uses two physical agents of a conservative nature. And I think it also really helps to outline what the environment, potentially looks like. So this is combining shockwave, focused shockwave, along with a low tension spinal distraction or traction, as most people might call it. It is an animal model study. But what they did do is they looked at, that environmental effect. So the idea was to look at, what does the effect of mechanical separation, decreasing the overall pressure within the environment that we're actually trying to heal. And I think it's interesting because, again, some people may use this in their particular clinical setting. So essentially what was found was, that environment that was created by the low intensity traction was effective and considered, part of the process at which, they saw some reestablishment of end plate growth and potentially what was also going on in the discal material. And it sort of outlines, the potential opportunity that we have, certainly when we combine these two things. Now, they were using low energy, traction. They're also using low energy extracorporeal shockwave. We have another study coming up here that also looks at, some of the differences and the dose response, because that's also important when you're evaluating the literature. What was their dose response, and did they meet and or exceed a threshold. And again, that's an area where I think we're still trying to figure some of that out to determine, where that lower threshold is and where the higher threshold was. So in any event, the conclusion was that, combined with these two effects, there's not only, potential regeneration in, end plates, damaged end plates, but also in the matrix of the discal material. I mean, that's kind of the take home from this. And I think a supportive component to why we might, introduce this to a patient. This next one, specifically on the end plates, and similar to the previous study in that, it was an animal model, but also looking at the evaluative effect of a damaged end plate, which is part of the degeneration model that we have in humans, and certainly, part of the influential effects with regards to the low back pain and neck pain criteria. So what was interesting is they used, the 5 different groups. One of them was a sham group, but they were looking at the evaluative effects of that dosage response. And when we look at the use of shock waves, so 2 ways we mitigate that. One is going to be the overall intensity, and then the other one's also going to be the impulses, to look at the cumulative introduction of that energy into the tissue. And what they found here was, adding approximately another 50% of the energy did make a difference. And in fact, it was significant. So we know that 2 things from the study is that, it can be influential with regards to the accomplishment in influencing. So the groups that were treated with the 21 kilohertz actually showed significant fibroblastic activity, significant neovascularization at the intervertebral end plate, which is significant also if we think about, the pathophysiological process of degenerative disc and where that actually initiates. The other thing that we see from this particular study is it's dose dependent. So that's something also to take into consideration when we are looking at, certainly looking at the literature, but also in the application in the treatment effects. Spinal fusion. So this particular study was done looking at the evaluative effects of combining, shockwave in the healing constraints following a spinal fusion effect. So it was another histochemical evaluation of a procedure. I think what's interesting is when we see, it was significant. So in other words, the numbers showed that there was enhancement to regrowth, osteogenics around where the fusion took place in basically supporting that particular procedure. And then in some of them, and it was they were considered a self-control. So one side was treated, the other side was influenced with the same introduction of injury, but the opposing side was not treated. So in the histomorphological evaluation of this, it did show that significance was in the direction of the treatment approach. What was interesting is when you look at some of those morphological changes, and not all of them experienced that. I find that particularly interesting, and I think it goes back to the dosage response that we need to take into consideration. But in general, it seemed to be effective at enhancing the spinal fusion in rabbits. I think the other thing that's interesting about that is, oftentimes we look at where contraindications come from, and some of them are just rather subjective. And so this also shows that not only, well, maybe we need to rethink that contraindication and also consider, the potential opportunity for healing, accelerated healing with regards to some of our more invasive procedures, such as surgical fusion. And these subsequent studies I've talked about before, but it's looking at the neurogenic protective effects, and in showing that, we do have cell proliferation in the in the peripheral nervous system following, injury, either more proximal or at the spinal cord level. So again, it's showing that neuroprotective effects that we can get from, as well as, the potential opportunity for treating the neuropathic events that patients may experience, from a disc herniation, radiculopathy presentation, or, lateral canal. And again, to reiterate, when we're looking at, facet imbrication, facet syndromes, and even though I think the literature is unfortunately very limited in some of those aspects, but that it has been shown, to be chondroeffective, for example, anti-inflammatory effective, for example, in other synovial joints that, arguably we could say would be very similar to, some of the areas surrounding of the spine. Also, when we look at the pathophysiological process of a disc herniation or an inflammatory response in the proximity of the spine and its influence on the intrinsic musculature, as well as some of the extrinsic musculature in the neurogenic effects, but also, and, I look at the fibrotic effects. I've mentioned I just want to, throw out a brief case that I didn't publish, but I followed it very closely and was easier to follow closely because it was a colleague of mine who presented with, he was about 4 months post-injury. It was a skiing accident and resulted in significant low back pain and radicular pain, complete absence of S1 nerve root, deep tendon reflex, also had atrophy, significant atrophy by the time I saw this patient in the upper thigh, in the circumference, weakness, significant pain, reducing, he was a chiropractic physician, reducing his work output by over 70%. So there was a significant reduction in his occupation. And to kind of cut to the chase, so by the time I had seen this particular patient, he's been through 2 courses of physical therapy, had been seeing a chiropractor, had scheduled the neurosurgeon consult and the MRI, and was preparing for surgery, especially given his neurological deficit, which was pretty significant, including weakness. And so it took approximately 5 visits, but on that 5th visit, it was noted that there was a 0 out of 10 on pain, and still significant in decrements in function. But again, my consideration when we look at this literature and the implication that I had when the only thing that we added to his treatment regimen was the shockwave therapy, in that I think that this further goes to, the benefits that we had, especially from the neurogenic effects. We added an electrostimulation strengthening protocol. It took approximately 4 to 5 months to get him to 80% function again. But considering his neurological deficits, that was pretty significant to be able to accomplish all of that really from a conservative approach and not have to have subsequent surgical procedures. And 1 year follow-up, he is 100% pain-free, seems to have fully recovered, is back to full occupational status and no limitations. He's also a recreational competitive triathlete, so very, very active person. Well, anyway, I hope this was helpful, and that I look forward to the next one.